That's me. I'll be talking on introduction of the course, pathomechanisms, conventional laser and micropulse lasers in diabetic macular edema. We would like you to understand DME based on evidence-based data. What is the latest classification? What are the various modalities of treatment available? If we have time, we'll have some panel discussion. So DME essentially occurs, there's a predilection to occur in the macular area due to loose binding of inner connecting fibers. It occurs between the inner plexiform and outer plexiform layer. And you must have heard of focal maculopathy, or diffuse maculopathy, and ischemic maculopathy, and clinically significant macular edema, which is defined in the ETDRS. And all of us, all the residents, before they go for exams, they must know the three criteria how clinically significant macular edema is defined. However, the drca.net has come up with a very simple classification which most of us should understand, and that is a center involving DME or a non-center involving DME. Why this is important? Because if the center is involved and the patient is symptomatic, we treat them with anti-VEGFs. If the center is not, if it is a non-center involving, you follow the ETDRS guidelines and treat them with focal laser. So this is a non-center involving DME. You can do a focal laser for the macular edema, which is not involving the center, because the macula is absolutely fine, the vision is good. Here is a patient where there is a central involving diabetic macular edema, and these patients obviously can't be lasered, and you have to treat them with anti-VEGFs. The center involving DME can be further classified based on the subfield on the right eye and left eye, and each subfield you could actually give it a name and classify it, though it becomes a little too complicated, but yes, you can subclassify it. A little bit about the pathogenesis of DME. Essentially, there are changes which are occurring in the basement membrane. There's loss of pericytes. The 1:1 ratio of endothelial cells in pericyte is disturbed. There are changes in the endothelial cells. There's changes in the stickiness of the platelets, and all these features put together leads to occlusion. This occlusion leads to formation of microorganisms, which are basically the sites where the neovascularization eventually is formed, and these microorganisms eventually lead to leakage, which occurs in form of a retinal edema, hard exudation, which occurs in the macular area. The occlusion also results in formation of vasoformative factors, which is evident on angiography as the CNP areas, and this leads to neovascularization. Now, there are various biochemical markers. I will not go individually into it, but just to tell you that the essential pathology in diabetic macular edema or diabetes as such is hyperglycemia. There are various pathways involved: the oxidative stress, the advanced glycation pathway, PKC activation, inflammation, orbital pathway, and the renin-angiotensin system. Now, all this causes a vascular endothelial dysfunction. There's retinal ischemia, and you can have targeted approach. If you have retinal ischemia, you could treat it with laser. If you have, you can have steroids which will act at the level of inflammation, vascular endothelial dysfunction, and vascular permeability. Then you can have anti-VEGF, which is for the blocking the VEGF, and there are other minor pathways which we will not go into, using the boxystorin and the somatostatin, which we will not cover during this course. So essentially, the optimum combination treatment for diabetic macular edema is metabolic control, use of anti-VEGF, focal laser, steroids, and doing scatter laser or vitrectomy. I would briefly touch, because it's not being covered by others in the course, is that metabolic control is the key to all cases of diabetic macular edema, irrespective of what treatment you give. And this is a slide which I borrowed from Dr. Mangat. So this is a patient who refused all interventions. 6 months down the road, this is the right eye, no intervention, and you can see a beautiful reduction of changes in the macula just by a very strict metabolic control, right eye, left eye, which is very, very evident. So this is one of our patients who had similarly very good response, again refused treatment, and 24 weeks later you can see the change. So the essence is that all patients, irrespective of what treatment you give, metabolic control is a sense. Even if you have to do a vitrectomy, metabolic control is important. Briefly about lipid lowering agents, a beautiful publication from PGI which showed that lipid lowering is useful in these patients of altering the microarchitecture of the macula. and the visual improvement. You need to control proteinuria, and this is some examples of good control of proteinuria. The macula improves. The other thing which is important is control of hemoglobin, and this is a patient with, I have shared this at many platforms, a patient with thalassemia who had multiple lasers, multiple anti-VEGF injections. The anemia will not get corrected beyond 9.8. And eventually, this patient had to undergo vitrectomy. This was a non-tractional macular edema. The vitrectomy improved the oxygenation. So these are the patients where anemia also needs to be controlled. Briefly about laser photocoagulation. Conventional laser, you can either, so these are the various parameters which you should know about. They're taking informed consent, using topical anesthesia, and there are various burn parameters. What are the choice of lenses? And for the scatter, you can use LIO. These are the various parameters which you can, so this you can all look up, but essentially let's look at, so either it could be a focal treatment, as we said, that is for a focal macular edema, or as was done previously where we used to have this grid photocoagulation. So much grid is not done anymore, or you can have a modified grid therapy, which can be done in combination with anti-VEGFs or steroids. These are some of the examples of patients who have been treated with focal laser during the years when we did not even have anti-VEGFs available, and patients did well. But of course, they did have problems with a scotoma, which we never bothered about because the patient had very good visual acuity. This is again some examples patients who were treated with laser. Again, a combination of anti-VEGF followed by focal laser. The patient has received Avastin, the edema comes down, then you go ahead and laser them. Now, briefly about micropulse, I'll rapidly go through it. So this is how we used to treat. We used to have a patient at the end of 1 year having a very good visual acuity, but having a paracentral scotoma, and in some societies where paracentral scotoma can take away your driving license, the patient is happy that the vision is good, but the driving license is gone. So ETDRS and DRS came up, they observed that in their treatment, when the suprathreshold laser was used, the area around the laser burn actually contributed towards the reduction of diabetic macular edema. So from here came the role of subthreshold laser. A subthreshold laser is actually not same as a micropulse laser. A subthreshold laser, even if you reduce this duration to 10 milliseconds, you will still get changes on the OCT, which would be documented changes after the laser. The micropulse laser, after being treated, does not leave a mark. So micropulse laser, basically you need to adjust the duty cycle. We normally work at the level of 5% duty cycle. And there are various publications now. This was published in Retina, which compared patients with a normal ETDRS protocol versus a micropulse, and they found that the micropulse laser improved microperimetry and did not show any change in the fundus autofluorescence. Same thing was proved by Levinsky et al. Here, this is one of our patients who we treated with micropulse, and you can see here, this was a grid pattern used 200, 200, 200, and you can see here, patient responded extremely well. Now, this is an interesting case. This is one of my recent cases where I have done a micropulse pan-retinal photocoagulation. It is not documented, but yes, we have now collecting data where all the areas of NBE were treated with pattern laser. Then I demarcated the area where I wanted to do. So this area is only a demarcation so that I know where exactly I'm going to do a micropulse laser. This is a follow-up of about 3 months in this patient. This is the initial OCT picture, and you can see here there is a reduction of the macular thickness by doing a micropulse in the central area. The patient is extremely happy, and there is no new NV which has come up. This is the left eye of the patient. Again, the patient was treated, had the NV was treated with pattern laser, and rest of the area we did a micropulse. You can see here the central subfield has improved and the areas around it are improved. So patient overall is doing well. And so micropulse laser in these cases is doing well. I would now request Dr. Neeraj to talk on clinical trials.